their concern with everything that you just talked about is that the healthier, more able-bodied will likely drop out of Medicaid, and the sicker, more expensive patients will stay in it, and that the risk profile of being in that part of healthcare will become really difficult to maintain. Is that something behaviorally that you could see if these changes happen in the real world? Welcome to Insuring Growth, where health insurance leaders come together to discuss policy, strategy, and the business of health insurance. I'm your host, Brendan McLoughlin, president of E123, the industry's only distribution management system designed specifically for health insurance. On today's episode, we will dive into the Trump administration and its broad impact on the health insurance industry, from carriers down to kitchen table agents. Just a quick note before we begin. This episode was recorded at an earlier date, so keep in mind that timing may affect some of the context. That said, the conversation offers valuable insights we're excited to share. Let's get into it. Our guest today is Dr. Michaela Lavender, a health economist and assistant professor at the University of Nevada, Las Vegas. Her research interests center around analyzing how people respond to public insurance and health policies. In particular, she's studied how Medicaid and marketplace insurance impact pregnancy and labor market outcomes. She's passionate about health insurance literacy and educating her students, and now our podcast listeners, about the health economics and health policy issues that affect every one of us.
I'm glad to be here. There's a lot going on, and it'll be fun to talk through it.
Terrific. Thank you so much for joining us on the podcast. Last time we spoke, we were on stage together at Medicarians in Las Vegas, specifically talking about Medicaid. But there's so much more going on, so I'm very excited to hear your latest thinking on how the new administration is going to impact health insurance.
Yeah, when we talked before, there were some things that were still up in the air of what's going to happen with some of the Medicare proposed rules becoming finalized rules. We also now have this one big, beautiful bill being passed through that's supposed to do quite a bit on health. And so there's a lot going on.
Okay, so I know it's a lot to ask, but I think our listeners would love a 30,000-foot view of, in broad strokes, what are the big impacts that the administration is going to have on health insurance, both this year and over the next, 3.5 years?
Yeah, I think that's a great question. When we were on the campaign trail, neither party was really saying a whole lot about healthcare policy. And then in the first half of this year, a whole lot has happened. And so, like most of the things going on in the Trump administration, it's been a little bit hard to keep up the pace with everything that's happening. And it's coming from multiple different angles. You have executive orders, you have CMS proposed rules, you have the legislation that's gone through the House and now is working its way through the Senate. And a lot of these things have the potential to impact Medicaid. The marketplace has had a lot of changes proposed, and also Medicare. The big kind of themes that I think we're seeing is a general concern about fraud, waste, and abuse. And that kind of 3 keyword phrase is even like a CMS topic header that you can click through and read different things that relate to it. So that's definitely a big focus.
It seems to me that's a bit of a departure from the first Trump administration. Is that the way you see it?
I'm not so sure with the first Trump administration how much they were concerned about the inner workings of the systems in terms of fraud, waste, and abuse. I think they were much more focused on just dismantling the Affordable Care Act. And that was the big focus. So I do think that this is more of a fine-tune approach where they've come to accept that the Affordable Care Act is there, and it's been around for 15 years now, and they're much more focused on fine-tuning things within it.
So I guess it would be a mistake for people in the insurance industry to think that this Trump administration is just going to be a redo of what we saw 4 years ago, right?
Yeah, there are some themes that were in Trump 1.0 that we've seen come back. Some things like scaling back marketplace subsidies, especially I think within the marketplace, there's a more return to the past flavor. If you think about what was happening with the repeal and replace they had a whole bunch of things and they kept trying to scale it back to get something passed, and things just weren't getting through. And so, you ended up with the individual mandate being repealed. They got the cost sharing subsidies repealed for the marketplace, but there wasn't a whole lot that really changed. And actually now they're planning on bringing back the cost sharing subsidies. So that's a very interesting change in what's going on there.
Maybe it would be helpful to give everybody some context if you could talk through a little bit, who are the people and the departments that really matter for health insurance policy? There's lots of names that we hear, but we obviously know that the president's got a lot on his plate. So who are the people and the policymakers and the departments that are the ones that we need to be paying attention to?
Yeah. So when you think about like the U.S. Department of Health and Human Services, that's kind of like this umbrella organization that has the Food and Drug Administration under it, and then the FDA, and then the Center of Medicare and Medicaid Services, CMS, and then the National Institutes of Health, NIH, all of these terms that we've heard a lot in the news, those are all under the HHS. And there's been some cuts proposed to HSS. And then you have to think about, well, where in the system is that? A lot of the policy changes when we're thinking about health insurance is really on the CMS side of things.
And CMS isn't just Medicare and Medicaid. Do they impact broader parts of the market?
Yes. CMS is really important too for the General Affordable Care Act policies and doing the rulemaking related to that. So things like the marketplace are heavily impacted by CMS decisions.
Let's talk now a little bit more specifically. What are some of the 3 or 4 very big changes that you see coming that are either already implemented or you can see are clearly going to happen that we should be aware of?
So the main one that's been getting a lot of attention, even in the popular media, is this issue of Medicaid cuts. That's in the One Big Beautiful Bill. And so that has a couple of pieces. The details are obviously still being worked out. Maybe the Senate can kind of push back on some of those changes. So that's one part. The marketplace changes, though, I think are not getting as much attention, but there's a lot happening there. And what's really interesting there is it's being impacted not just by the One Big Beautiful Bill, but also by this CMS proposed rule that came out in March. A lot of the same policies are in both of those processes that are chugging along. So even if, something happened with the One Big Beautiful Bill, it could be passed through CMS rulemaking. So that's a lot that's happening. And then we've also seen some changes with Medicare. That's more on the CMS side. That's not really happening in the One Big Beautiful Bill. And then there's also been some more things like with health savings accounts being expanded. That's part of the One Big Beautiful Bill. That's something that did go back to the Trump 1.0 era, is they really wanted to expand health savings accounts. So that idea we see has been brought back. And then there's also some kind of interesting things with what were called individual coverage health reimbursement accounts, which were where employers could contribute to the premiums for their employees to get insurance on the marketplace. So kind of at this intersection of employer-sponsored and marketplace insurance that got introduced in 2019. So again, during the first Trump administration, hadn't really gained much traction. And now we're seeing in the One Big Beautiful Bill that they're trying to expand that option a bit more.
Professor Lavender, you mentioned that a big theme for the administration is addressing fraud, waste, and abuse, especially within CMS. What are some of the other big themes that you think are driving the policy making and the decision making in the new administration?
I think another one is personal responsibility and consumer sovereignty. We see this with the work requirements for Medicaid. They want people to be working at least 80 hours a month in order to qualify for Medicaid. We also see things with health savings accounts expansions. That kind of puts more of the payment for care onto the individual and encourages them to save and invest for health needs in the future. There's also been some things about like price transparency and trying to give consumers the tools to better make decisions about their health care, and even some like very small details like there can no longer be auto enrollment changes from bronze plans to the cost subsidy reduction silver plans if people are eligible for those. So that's just kind of a whole theme that I think we are seeing reach into multiple areas.
So let's talk a little bit more about price transparency. Most of our listeners are in the health insurance industry. I think we in the industry would say that our piece of the health value chain is pretty price transparent. Are they talking about the price of a health insurance policy? Is that where the transparency focus would be?
No, I think it's much more in the price of care. You're right that the price of like premiums and what's the deductible, what's cost sharing out of pocket, all of that is pretty transparent. And you think about the marketplace really listing that out side by side for all of the plans. What this is more concerned about is prescription drugs and hospital charges. Those are the really big ones. Both administrations, the Biden and the Trump administration, have been doing some things, particularly on Medicare, to make drug prices more affordable, also more transparent. And so those pushes are still going to be going through. With hospital prices, the Trump administration tried to get hospitals to post 300 shoppable conditions where the hospital had to say what price they have negotiated with every insurance plan that they have. And so this is a really massive data undertaking held up in courts, and the Biden administration didn't really push it forward that much. But now Trump has said some things like, we are going to update this and we're going to try and get that data out there to consumers. I think what that does to actual consumers is very much up in the air. It's really hard to look through those shoppable files, even when hospitals have compiled, which hasn't been perfect.
So even if this policy happens in the real world, how realistic is it that regular everyday consumers are going to be shopping for health services? Is that realistic?
No, it's probably not super realistic. I'm a health economist and I like thinking about these things. So I was just like, well, let me go see like a vaginal birth at different hospitals. What's the price? Right? That's pretty straightforward. And the files are really hard to go through. And it was very challenging. And to find your insurance, it's not super easy. Maybe they make it easier. But even if that data was readily available and comparable across multiple hospitals, consumers don't really care because they do have, insurance. And so they're not paying the negotiated price. They're paying a copay or co-insurance, or maybe they've even hit their out-of-pocket max. And so in some sense, the demand for care is very inelastic and then made more inelastic by health insurance. So it's not necessarily clear that on the consumer side, they're going to respond to these changes. On the other hand, the market could respond. Like if hospitals see, okay, this insurance negotiated this price with that hospital, maybe that enters into their negotiations and maybe that affects prices.
It's absolutely something that health insurance executives need to be aware of and keep their eye on. If policyholders and potential members have much more visibility into the deals that they've struck with providers, it could enter into their decision making, and it's something that should be, I think, understood and planned and strategized by health insurers, not just let it happen to them. So that's awfully interesting. What other big picture themes are you seeing coming from the administration?
I think there's a definite focus on trying to save money from the federal government on health. And so part of this is with the one big beautiful bill, they are obviously extending tax cuts, and that's expensive. So they're trying to cut back in other areas.
And all of the news and everybody is talking about this $800 million from Medicaid. Is that, or billion, I guess, from Medicaid? Is that a real thing? Is that based in reality, or is that just a talking point?
Yeah, I mean, that's their goal, right? And it's over 10 years, so it's not maybe quite as drastic as it sounds. But the way that they're going about doing those Medicaid cuts is, one, they're adding the work requirements for that kind of ACA expansion group. So not children, elderly, disabled, but working adults. They're supposed to work 80 hours a month. And then the other part is they're reducing how much the federal government subsidizes states on that expansion group if that state, with state funds, covers immigrants with health coverage. And so the federal government isn't paying for those immigrants, but some states have more generous coverage options for immigrants. And so the federal government is penalizing states who have decided to do that. And that is a reduction from 90% of the federal government contributing and 10% is coming from state funds, down to 80% for those states. So there's a whole bunch of things that could actually, how does that impact people's decisions and states' decisions? And that'll determine how much cost savings there are. With the work requirements, most of the people who are on Medicaid would actually meet those work requirements. The way that there's going to be a massive cut is they're going to get caught up in the red tape, and they're not going to re-verify their income or document their hours. And that's what would cause a massive drop.
Right.
That's a little bit on the behavioral side. It's a little bit hard to estimate. On the other side, it might be that states just drop coverage for immigrants and then they don't get that reduction in the FMAP. Or it could be that the states are going to have to contribute more from their state funds, or maybe they scale back Medicaid in other ways to kind of reduce how much they're paying. So there's definitely a lot in the air. That is what they're planning to do. There's definitely cuts to Medicaid, and it'll be interesting to see how it ends up working out.
That's very interesting, Professor Lavender. So a number of our clients and the organizations that we partner with are community health plans that largely focus on the Medicaid population. And I think I speak for them that their concern with everything that you just talked about is that the healthier, more able-bodied will likely drop out of Medicaid, and the sicker, more expensive patients will stay in it, and that the risk profile of being in that part of healthcare will become really difficult to maintain. Is that something behaviorally that you could see if these changes happen in the real world?
Yeah, this is the common adverse. And I think that there is some validity to this, right? If the people who really need Medicaid because they're going to the doctor frequently, they're aware of what's happening, and they're going to be more likely to make sure they're documenting their income and their hours, and they're staying enrolled because they're using the care. It's more likely going to be those people who enrolled because it was easy, but they go to the doctor once a month or once a year. They're going to be the people who get dropped, right? Because they're just not paying attention. And so the cost savings there could be smaller than expected if it's really just those people who weren't utilizing care anyways who get dropped. That's going to be a little bit different. So you could end up with an overall sicker population. Now, again, the way that the government reimburses plans is based on risk scores of those people. And so it's a little bit more nuanced than just how many comorbidities does this person have. It really comes into that propensity to actually use care given your risk score, right? And so that's where whether or not someone is engaged or checked out is really important to understanding the cost to plans.
That makes a lot of sense since the reimbursement is tied to the risk factors. It's not necessarily a death spiral. Perhaps a bad choice of words.
Well, a death spiral is really important when we're thinking about insurance terms, right? Is that the pool gets sicker, and so the premiums go up and people then leave because the premiums went up. That's not really what's happening here because the individuals aren't the ones paying the premiums. But the state is, right? Someone's paying these premiums.
Oh, do you know anything about the short-term medical?
Not really, no. And I haven't seen like anything in my deep dive really touching it either. So I think if things end up impacting short-term medical, it's more from the substitution effect rather than from a direct policy impact.
The thing about it, if last I saw, Congress had a bill extending short-term medical to 12 months with a 3-year renewal cycle. If that happens, that creates an economic interest for the agents and brokers to market those products, to literally market against the exchange, because they're not as robust, so they're less expensive. And for lots of people when they need short-term medical and they're paying for it themselves is, when someone in the middle class loses a job. And, maybe that's a time where you can give up some of the benefits that you would get on an exchange product. So it's an interesting dynamic. I think it's more the value chain has an interest in making that available as an option more so than the government necessarily saying that this is, a priority in any way.
Yeah, I think when people lose their jobs, right, they take an income hit too. So in that sense, maybe the marketplace does become a little bit more attractive. But like if you're between jobs, like at the end of the year, if you lose your job, well, your income is pretty set for the year and you probably can't do much and you might not get a subsidy. If you lose your job in the beginning of the year, well, how long do you think it's going to take you to find a new job, right? So that is an interesting dynamic if you don't really know your income, so you don't know your subsidies in the place where a marketplace plan could be helpful. You just don't know your income for the year. So that's really tricky.
For decades now, we've had fairly untumultuous job markets, right? So people lose their jobs all the time, but that feeling of losing your job and not knowing if you're going to be able to get another one isn't as prevalent now as maybe it was in 2008, 2009. And so I think a lot of people in the market today are very distant from that feeling of not knowing how you're going to possibly provide healthcare for your family.
Well, I think you mentioned families, but I think it's a bigger issue for, single income families, right? Oftentimes, if you have two spouses and one loses their job, well, they just become a dependent on the other, spouse's insurance until they get their own job and they move back off, right? So it is really these single income, whether that's a single person or just one person is working, where the risk is.
Well, and I also think, I think it would be interesting actually to see the numbers, and I don't know if anyone's done the research, but there are households where there's a dominant wage earner, but not a single wage earner. And the dominant wage earner is going to have a more likelihood of having employer-sponsored healthcare. The secondary wage earner might be part-time, might be minimum wage, might be odd jobs, might be freelance and not have health insurance. And when the primary loses not only a big chunk of the income, but also the health insurance, and if they lose that in November, it would just, and COBRA is insanely expensive. It's just shocking. I mean, the options for somebody who is a decently compensated person who loses their job in October, who has a partner or a family that earns but doesn't earn a lot, it really sets up some difficult dynamics there for the next few months.
Yes.
Well, unfortunately, that's all the time we have today. I think we could spend hours talking about the broad impacts of the new administration on health insurance in the U.S., but I really want to thank our guest, Dr. Michaela Lavender. Thank you so much for sharing your insights. I think our listeners are a little bit more educated and might be a little bit more prepared for this open enrollment. So thank you very much.
Thanks for having me. It's been fun.